and you're looking at what, maybe 30 frames a second, and they want to do 10 seconds of fluoro. So 30 frames times 10 seconds, that's 300 frames times, probably they're going to use a mag mode. It's a lot. That's for a 10-second run. Cardiology, cardiographic special procedures can result in pretty high frame rates. The other one is neurovascular. Neurovascular is the only procedure in my tenure where I knew for a fact that a patient had, multiple patients had temporary hair loss. Neuro takes a lot of time, takes a lot of fluoro.
The OR.
Anybody seen one of these?
We just bought one.
If you're at Kaiser, you should see them. I don't know if any non-Kaiser facilities have these.
We just bought one.
You just bought one, aren't you lucky? Okay, this is an OR.
This is my facility.
I would call this the poor man's CT, even though these things are really, really expensive.
I think it's big
What
and clunky
happened
too.
to this is kind of an interim situation because there are mobile CT scanners. A lot of facilities that invested in these at great expense are now saying, oh, well, we can get a mobile CT that does a better job than this. No, we already bought you that. You're stuck. This is classified as a C-arm. The reason is because it's basically a C-arm that rotates essentially infinitely. It'll do a 360-degree rotation. So for the settings for this is basically you have a single acquisition or a double acquisition. The controls are pretty much like any C-arm control. Again, this is something you push. It opens up like a big clamp, and then you close it down. The manufacturer, in their literature, suggests that during acquisition that you leave the room. Scatter from a CT scanner is pretty extensive. Scatter from this is pretty extensive. I think I have that. Who cannot leave the room?
Patient.
Besides the patient. Nice one. Who else cannot leave? Anesthesiologist. You don't give them just a regular mobile shield like you use in X-ray. Doesn't have enough lead. You give them one of the see-through leaded plexiglass shields like they use in nuclear medicine. Those have about 1.5 millimeter lead equivalency or a little bit more. So they're much safer behind that during these procedures. There are doctors who decide to stay in the room, and where they stand actually is pretty smart. They stand at the back. And I think I have the scatter. Well, this is what you get. These are used basically only for neuro procedures, so it allows them to get into vertebral bodies, to get into nerves. Pain management is really big on these, but mostly it's neuro and neurovascular. Here we go. So, this is the big donut. And some doctors elect to stay here. I'm not real thrilled about that myself. I suppose if I was a surgeon and I had a patient that was iffy and I had some concerns, I would probably stay in the room. My half-pound lead equivalent apron should be sufficient for the occasional case. And of course, the anesthesiologist should have his equipment somewhere towards the outer lines here with his shield. But yeah, this is pretty. Now This has a spherical phantom in it. So if you put a person in it, what are you gonna see? You're gonna see this come in, and you're gonna see this come in a little bit, depending on which end is the head. But if they're doing neuro, then the head's not gonna do much, but you'll have a distinct shortening of the body side of things. If they're doing a lumbar spine, then this whole thing will just shrink in a little bit, okay? Okay, that ends this. Anybody have any questions? So next week, what you need to read